So this next lecture is going to talk about sepsis and a little bit about septic shock. For my students and for everyone else that's listening, the septic shock, I'll go in more detail when I talk about all the shocks. So that lecture's coming here soon. But right now I want to talk about sepsis and septic shock briefly. So let's get started. So sepsis is an infection that the body responds to. It's a systemic infection. Inflammation will take place systemically. Over 250,000 deaths per year are due to this condition. And I'm just going to go and say this slide is probably based on data maybe 5 to 10 years ago. And so it's probably even more now than that, but approximately that, which is quite a few people who die from sepsis. So there's different stages when we're looking at sepsis. So the first stage of sepsis is we're going to see an elevated temperature. We're going to have a fever above 101 degrees Fahrenheit. Second thing we're going to see is a respiratory rate above 20. We're going to be tachypnic. Third, a heart rate above 90. So we're going to be tachycardic. And then a confirmed or possible infection. During this stage, one of the things that I want you to realize, the number one cause of sepsis is UTIs, believe it or not. And where do we see UTIs? We see them a lot in our elderly population. So understand that when we see elderly patients that are totally out of their mind, confused, unable to walk. I had a family member tell me once that their mother, they thought she had a stroke, but she literally had a UTI and was septic with a UTI. So it can be very detrimental, and if not treated, it can actually lead to death if we're not careful. So this initial stage, we're going to have a decrease in cardiac output. So we're going to have a decrease in perfusion. And we're going to switch to a survivor mode for our bodies. We're going to switch to a survivor mode and go to an anaerobic metabolism. And what it does is an anaerobic metabolism makes lactic acid. So we're going to have an elevated lactate, right? So an increase in lactic acid in the blood is going to decrease our pH. If we decrease our pH, we become acidotic, right? And what happens is our liver can't break it down. It can't break the lactic acid down. So we become metabolic acidotic. When we looked at AKI on another lecture I just presented and posted, we were metabolic acidotic there for other reasons. But here we are again looking at this. This is the initial stage. And just remember, we're going to have a fever go up, put your arrow up. Respiratory rate is going up. Heart rate is going up. Everything's on an upward motion, right? Because this is the beginning stage, the initial stage of sepsis. So our next stage is a severe sepsis or a compensatory sepsis, sometimes you'll hear. For my students, I just want you to understand their stages. This is the first stage. We're here on the second stage. It's progressed and we're starting to cause organ failure. So in the initial stage, if we intervene, we can prevent organ failure. If we don't, we're going to progress into severe sepsis. And when we get to this stage, our cardiac output is going to increase, our respiratory rate is going to increase, and we are going to start to hyperventilate. We're going to become tachypnic. We're going to want to breathe fast. Our sympathetic nervous system is going to kick in because we have had a lower blood pressure, and so we're trying to maintain homeostasis. And when our sympathetic nervous system kicks in, our blood pressure is going to increase in severe sepsis at this point. So we're going to have a decrease in urinary output. The body's going to try to hold on to everything it's got. It's trying to fight. We're going to have a decrease in neurostatus. So you're going to see a change in altered mental status in your patient. Discolored skin and patches all over the body. They're going to be tachypnic. We just talked about that. Extreme weakness is going to be seen. And the body temperature is going to begin to fall, and the patient will chill. So they're going to be freezing. They'll be shuddering. And what does shuddering do? It causes us to work harder. You never want your patient to shudder or chill and shake from cold. We want them to not do that because they're going to need more energy. They're going to burn more energy, and we don't want that. They're already at a high demand. They're needing everything they've got to try to fight this so that they can turn it around. And they're going to have decreased platelets, and that means they're at a higher risk of bleeding. And that is not good. So if we're at a higher risk of bleeding, if there's anything that was, say they had surgery or something like that, then they're at a risk of bleeding. If they fell, whatever the cause, but it's going with the decreased blood platelets, we're going to be at a higher risk of bleeding, which is not good. So these are those signs and symptoms. The renin-angiotensin-aldosterone system, what happens is our sympathetic nervous system. I remember back in your, go back to your class of anatomy and physiology. So we have this going on. Our sympathetic nervous system kicks to get our blood pressure up. The catecholamines, epinephrine and norepi, those things that are in our bodies, the fight or flight, the things that we need, are going to initiate to cause vasoconstriction. So we're going to try to tighten down our vessels. When we do that, that's what causes our blood pressure to go up. I want you just, because you've heard these terms, so I want you just to hear them again. Then our renin-angiotensin-aldosterone system, and you remember that old circle of fun, it's going to kick, and when it kicks, we're going to retain water to help to increase our BP. So it's trying to maintain a blood pressure because we're compensating with breathing, our heart rate, all of those things are going on. And that is this severe sepsis stage, and we're starting our organ failure. So looking at severe sepsis, once again, it's sepsis. You've got that infection. It's systemic with organ dysfunction. We're starting to have organ failure, singular, evidenced by hypotension and hypoperfusion. And that's why our sympathetic nervous system kicks and a whole renin-angiotensin-aldosterone system kicks in, because it says, uh-oh, the blood pressure's down. I need to hold on to water. I need to create epi and norepi, and I need to tighten my vessels down because I'm hypotensive. Is that good for our body? No, but it's trying to survive. We need to perfuse, we need to oxygenate, and we need to have, we need to be able to tighten our vessels down to maintain our blood pressure. Our lactic acid will increase, and we've talked about that already. Our systolic blood pressure is going to be 90 or less. It'll drop greater than or equal to 40 millimeters of mercury of the normal. So let's just say I had 160 blood pressure and I'm down to 120. I've dropped 40. We need to be concerned, if that makes sense. We're going to have a lower pH. We're going to start to drop. We're acidotic, and we're going to have a low bicarb, because bicarbonate is the base that keeps us from being acidotic. With a low bicarbonate, we're in metabolic acidosis, and that's not good. Go back and review your metabolic acidosis. So the body is just kicking in every bit of its defense to try to maintain a BP, to perfuse the body, oxygenate, and keep it from going into a metabolic state of acidosis. but it's not working. It can't. And severe sepsis with hypotension despite adequate fluid resuscitation equals septic shock. So if I have severe sepsis, my blood pressure drops, I give them volumes of fluid because we need to keep fluid running through our blood vessels, right? We need to keep the fluid going. Start an IV and I'm running in the volumes of normal saline or whatever I need. It's going in, but I'm not able to maintain a blood pressure, then I'm in septic shock. So we keep on going into a progressive stage where we have a decrease in cardiac output. So we have a decrease in perfusion, which we decrease our oxygen. So we are in an increased anaerobic metabolism because we're not oxygenating, we're in an anaerobic state. And because of that, it just increases our acidosis even more. So it's kind of like a catch-22. So our cardiac output's going down, which decreases our perfusion. That means we can't perfuse oxygenated blood to the cell. When we can't do that, we don't oxygenate. We're not oxygenating, we can't have cellular life, right? Cells die, tissue dies. So because of that, we go into the survival mode of anaerobic. And when we do that, our anaerobic metabolism will increase. And when that increases, because we're trying to survive, because we don't have enough oxygen, we then become more and more acidotic, metabolic acidosis. Decrease in oxygen to the brain will have mental status changes. They will have had impending doom if able to speak to you prior to this. They are circling the drain at this point. This isn't good, but we still can intervene. We still can intervene, but we have things shutting down. We can go into DIC. We can go into ARDS. So DIC, we're going to have clotting, cascading issues. We're going to throw mini clots across our body. That then can cause a lot of issues. We're sending little micro clots to areas because we cannot get blood flow or oxygenated blood to these areas. We can go into ARDS, and ARDS is where we shut our lungs down. The lungs can't oxygenate. So the ventilator is trying, we usually have to intubate and ventilate at this point. The ventilator is trying to breathe for the patient, but the lungs are non-compliant. They're sticky. They're not going to fill up and be able to do our whole gas exchange with oxygen and CO2. And we be able to inhale that breath through the ventilator and be able to exhale the breath. That's not happening. We're having ARDS. We've gone into a shutdown, so we have to do a lot of different things. The thing about septic shock, as we're going into shock, it is 50% mortality once in shock. So no matter what, once we hit this point, our turnaround is 50%. So half of the patients will die. That's why it's so vitally important that you assess your patients, that you look at your lab values, that you look at your vital signs, you look at the intake and output. Those things all play a major role in what's going on in maintaining homeostasis. And when something is awry, you need to be able to intervene by calling the physician, by making sure that they're getting the fluids that they need, that their antibiotics are being given on time, or antifungals, whatever they're being given, that they're given on time, they're giving according to the actual prescription from the MD. Those things are so important. It's life and death. And this is a perfect example. And the number one cause of sepsis is a UTI, as simple as that. And we already know that men that have BPH, elderly women, postmenopausal women, females in general, smaller children with different disease processes, people with renal dysfunction, they're all prevalent and prone to UTIs. So there is a chance that your patient could actually be septic and you not even be aware. Don't make light of anything. Look for these signs and symptoms, look for the lab values, follow the trends, and intervene when necessary. So hopefully you can save a life. So before I start this slide here, the last stage, and we'll go through the stages again through these next few slides, is the refractory stage. And that is the stage that cannot be reversed. It's irreversible. When you get to the refractory stage of shock, sepsis, septic shock, it cannot be reversed. We're in multi-organ failure and death will occur. Simple as that. So let's learn a little more about shock. So shock is the lack of perfusion to tissues. Understand that, memorize that. That is the definition of shock. It's been the definition of shock. It'll be the definition of shock until we all are gone. So it is the lack of perfusion to tissues. If we don't perfuse oxygenated blood to our tissues, the tissue will die. Simple as that. So what causes shock? We can have hypovolemic shock, and I'll go into more detail next week on that, cardiogenic shock, neurogenic shock, anaphylactic shock, and highlighted here, septic shock. So for today, and for my students, we are only going to look at septic shock. But in the next few weeks, you will learn every one of these shocks because they're different but pretty much treated the same. So, signs and symptoms. We initially will have an increase in heart rate and cool skin. Second stage, we'll become confused, restless. We'll have diaphoresis. We're going to have a rapid, thready pulse. We're going to increase our respiratory rate. We've already talked about that with sepsis. Cool, clammy skin, decreased blood pressure. So we're going to become hypotensive, and that's what go ahead and kicks in that whole our whole system of our sympathetic nervous system so that we can start to try flight or flight and hang on to stuff, increase our blood pressure with the epi and norepi. We're going to have diminished urinary output. We're going to try to hold on to everything we have. When our blood pressure goes down, our urinary output is going to go down because the body wants to hold on to volume. It thinks it needs volume. It's where the brain is saying, hey, our blood pressure's down. Don't get rid of any volume. We've got to have circulating volume. We're hypotensive, so it's going to hold on to volume. And that's why you'll decrease in your urinary output. Now, really quickly, because we're looking at AKI and chronic renal failure this week on top of this shock, I just want to say this. If I'm not getting perfusion, I'm not getting volume flowing like it should and oxygenation to my body, am I going to have acute kidney injury with septic shock? Yes, I'm going to have AKI with all shocks because I am not filtering what I need. My GFR is not going to function correctly. I'm going to have issues. So because of that, my urinary output goes down and I'll probably see less than 20 milliliters per hour. That is normal in a shock situation because the body's trying to maintain homeostasis. So this is a great picture. I really like this picture. You can see it and read through it. I'm not going to read it, but this is showing you all what goes on with the body when the body goes into shock. It's not a good thing at all, but I want you to go through that, take a look at it. You can see we'll have flat neck veins. We're going to have decreased urinary output. There's just a lot of things. Our systems will shut down so that we can try to shunt oxygenated blood to the heart and the brain. So all other organs they just don't care. You know, it's like, what do we have to do? You got to have a brain and you've got to have a heart to survive. So the body says, who cares about the kidneys? Who cares about the liver? GI tract? No, we're not going to have good bowel sounds. We're going to shut it all down so we can keep the brain and the heart alive to hopefully maintain life. So we're going to see all these things take place. But as we shunt blood away from those organs, those organs are going to take a hit, and that's why we'll go into multi-system organ failure and shock if we can't correct it. So one of the things that we do in the clinical setting is we will do it's a tool that we use, and we're going to look at SIRS, systemic inflammatory response syndrome. We see it with sepsis and septic shock, so the different shocks. So what we do is we say, does our patient have a temperature greater than 39 degrees Celsius or 102.2 Fahrenheit? Or 36 degrees Celsius or 96.8 Fahrenheit. That is covering, if you look at those temperatures, it is covering the elevated temperature greater than 101 in that initial stage, but it is also covering the temperature where it starts to drop, because the temperature is going to drop because the body can't maintain. So it's covering both those stages in shock. When you ask these questions, if you answer more than, I think, 2, that's your patient, then they're at risk or are possibly in having SIRS. They're probably in shock. So we try to prevent or intervene as soon as we possibly can. If you have a fever, we're going to start looking because we want to get that taken care of. As you can see, our heart rate's greater than 90. We're tachycardic. Respiratory rate's greater than 20, or our PaCO2, we're looking at a blood gas, is less than 32. Our white blood cell count is greater than 12,000 or less than 4, depending, or we have greater than 10% Vance. So you're going to look at your CBC, your complete blood count. You want to look at those white blood cells and see what we see. Okay, so this is just showing you the things that we look at to see if we're in SIRS, sepsis or septic shock. So dealing with shock, and this is just talking about shock now in general. I want you to understand that. We're going to be hypotensive. We're going to have low blood pressure. We're going to vasodilate. We're going to open up our vessels. We're trying to get things flowing. Our system is going to not be able to clamp down and maintain a blood pressure when we're in shock. So we vasodilate. So that's why we have to give different medications and different shocks. And we'll go through those at a different time. I don't want you to learn those yet. But we're going to have hypotension. We're going to vasodilate. We're going to have a coagulation cascade. We're going to have excess clotting. That's where we can go into DIC, disseminated clotting. And that's where we shower many clots all over the body. You'll see patients with black fingers, black toes, blackened areas where they've necrosed, where little clots have gone and shut down blood flow. And so we see that with patients in shock. Malaise and fever, tachycardia, edema, tachypnea, we're going to breathe fast, hypoxemia, and low urinary output. So these signs and symptoms are what I want you to understand, or you are going to see with shock. If it's hypovolemic shock, if it's cardiogenic shock, whatever, we are going to see these. Neurogenic shock, we will see these different things. It'll depend on different shocks of how we treat and some other signs and symptoms. But in general, shock, these are your signs and symptoms. Know them. Now, this is how we identify, are they have an infection? So they're going to have increased white blood cells. They can have an increased inflammatory markers. There's C-reactive, the CRP that we see, ESR. Those are inflammatory markers. So when you see those in your labs, for my students, they need to put them in their notes because they need to understand that they're looking at the inflammatory process, inflammation in the body when those are elevated. They're going to have an increase in glucose. Why? They're going to release sugar. The body's going to release sugar because it's trying to make your energy. It's fighting for its life. We're going to have an increase in creatinine, bilirubin, and when we have an increase in these 3 things, we're having organ damage. That's what the organ damage is causing. It equals organ damage. We have glucose, creatinine, which we know creatinine is the byproduct of creatine. It's muscle breakdown, and bilirubin, which is liver, right? This is all equal to organ damage when these increase. Positive blood cultures, they've come back positive. And we're going to have impaired coagulation, increased bleeding time so we can bleed. Our INR and PTT, abnormal platelet counts. They're going to be bleeders. They're going to have the potential to bleed because they're not able to clot correctly, and that's not good. We're going to produce many clots, but then we'll be bleeding. It's like you would think it would be opposite, but it's not. And you have all of these things going on in shock. So let's look at our risk factors. An existing wound. It could be festering. It could have excessive drainage, something like that, and cause us to go into shock. Infection, which is your septic shock. Hospital or ICU admission. We poke and prod, don't we, and do different things. Your immune system is compromised when you're very, very sick. I always tell people don't bring your babies to hospitals and let them crawl around. I mean, it's a germ fest. Why would you? It's where every bad germ goes to live, is the hospital. HIV or cancer, of course, our immune systems are compromised, so we're prevalent to shock. Recent surgeries. We have gone through the skin, which is our primary protection. We have cut on and compromised the body. We can have different things happen like bleeding, different things like that with surgeries. Bleeding and infection are prevalent. Not for all, but can be. Foley casts or other devices, we're putting objects into people. That's why it is so important that you learn the proper technique. Stay sterile putting in your Foley cast. Stay sterile when you do your dressing changes that are called to be sterile. And other devices put in. Anything we put in the body is putting the patient at risk. That's why we're getting away from caths, Foley catheters, big time. Elderly, we talked about that. They have a compromised immune system. They are not, everything's decreased with the elderly, and because of that, they are prone and prevalent to going into sepsis and shock, or shock for any other reason. They don't compensate well. Very young has a compromised immune system, and they also, their liver, it depends on how the age bracket, but the very, very young, their GI tract is not developed, their liver's not completely, things are developing, and they're at a high, high risk to get sick and go into shock. So we need to just remember that. These are the folks that are at risk. These are your risk factors. So the clinical progression, it starts with a localized infection that leads to SIRS, which we'll see tachycardia, tachypnea, hypotension, oliguria. If you're not sure what that means, look it up. You need to know these terms: fever and signs of poor perfusion. Multisystem, that then will lead, if we don't turn it around here, it leads us to MODS, which is multisystem organ dysfunction syndrome. At this point, we're starting to see our organs be affected and shut down. That will lead us to disseminated intravascular coagulation, which is DIC. I've mentioned it a couple times. And Zygris, by the way, has been taken off the market. This was a drug that we gave, and it was to provide what the human proactive C would do. It helps with coagulation, but there were a lot of side effects, and you couldn't give it to a lot of patients. So that ended up being removed from the market. So now here's the biggie. Treatment. What are we going to do for these people? We're going to fluid resuscitate them with crystalloids or colloids to maintain their blood pressure and oxygenation. We have to give them volume. Remember back where it said they vasodilate, the vessels will open? Well, we're not able to clamp down anymore. If we can't clamp down, then we can't maintain a blood pressure. We stay hypotensive. So we're going to give them fluid. You're going to give them a big amount of fluid, crystalloids and colloids, depending on what the doctor wants. Remember, our crystalloids are normal saline, LR, D5W, and half normal. And our colloids are albumin and dextrin. Now, there's more out there, but these are the ones we normally see. We're going to intubate and mechanically ventilate because we need to oxygenate them. They're fighting and working. They're tachypnic. Their heart rate's up, blood pressure's down. They're circling the drain. We need to put a tube down. We need to intubate them. with an endotracheal tube and mechanically ventilate them so that we know they're oxygenating. We're going to send blood cultures, and then after the blood cultures are sent, always we will start a broad spectrum antibiotic therapy 1 hour after diagnosis of septic shock. It is important that you understand that these things are done quickly. It's a protocol, but they have found if we can start at 1 hour after the diagnosis of septic shock, we can turn it around, and we want to. Norepinephrine, dopamine, and dobutamine are inotropes and vasoconstrictors. I will break these down a little further for my students on another slide in another lecture. They do not need to know these at this moment. And we're going to give steroid therapy, because what does steroids do? They're anti-inflammatories, right? They're going to shut that inflammatory response down in hopes that we can turn things around and start to oxygenate and perfuse. That's the main goal. These treatments are so important to know. Go back through them over and over. What am I going to do as the nurse? I've got a patient in shock. I'm going to hang fluids on them. I'm going to go with whatever the doctor tells me, but probably crystalloids, normal saline, LR, D5W, half normal. If my patient were bleeding, I'd probably give albumin or dextrin, and we'll go in detail with hypovolemic shock when we talk about that. But these are the things we would give. We're going to intubate them and mechanically ventilate them. Just know that. We got to put a breathing tube down and oxygenate these people. We're going to send blood cultures immediately down. This should be going on as other things are happening. Somebody should be drawing the cultures, because we need to do that. And then we're going to start a broad spectrum antibiotic therapy 1 hour after diagnosis of septic shock. So we need to get it going. There's protocols here. We're going to use norepi, dopamine, and dobutamine. These are inotropes, which we'll go into detail on another lecture, and vasoconstrictors. I do not want my students knowing these drugs for this coming exam, but we will discuss them in detail on another lecture. You'll see them on another exam. And then, of course, steroid therapy, because steroids do what? They help with our inflammatory response, correct? Yes. So we're going to, the assessment for shock, it's an ongoing evaluation of the patient's level of consciousness, because they're going to go in and out, and we need to make sure. Now, if they're intubated, we'll probably be actually sedating them on the ventilator, but what you have to do is shut there are rest periods that we have. So we'll shut our medication off and wake them up to see if they wake up. I have a very dear friend who's a nurse practitioner. Her mother had surgery. She was in a lot of pain. They had her intubated. She couldn't wake up and come off the vent, so they kept her on the vent. She was having some issues, but they sedated her, and they kept her heavily sedated on the ventilator for 24 hours. And then after a full day, once she had come out, they woke her up, and she didn't wake up. She had a major stroke under the sedation, and she survived, but she was wheelchair bound and all that. So it's important that we rest them, wake them up just to see if they wake up, pupils react, all of that stuff we need to know. Watch for changes in trends in physical and laboratory findings. So you're going to be checking that, looking at all those things we need to know. We're going to look at vital signs too. We want to see what our blood pressure is, what our oxygenation is, what our heart rate is. They will be on monitor at all times, continuously monitored. And then timely reporting to the physician for treatment decisions. So you will talk to your doctor, and he will tell you what you need to do, and you will talk to him of what you find. So it's important that the communication's there, and you will find that doctors will communicate with you. They need to know what you're seeing and what you're doing. So MODS, just a brief thing on MODS, it's a multiple organ dysfunction syndrome. Septic shock plus evidence of 2 or more organs failing. That's what we have. That's what MODS is. Respiratory failure, this is when we see MODS. Respiratory failure, renal failure, liver failure, cardiogenic involvement leading to a cardiac arrest. MODS can result in death if not treated. So if we have these things going on, if we don't treat it, we can actually will lead to death. So for right now, for my students, I want a base level for you is just understand what MODS is and what we're seeing. That's all I want you to know. So I hope this lecture helps. This is kind of a down and dirty basic sepsis, septic shock, and a beginning to shock. So I wish you the best and have a wonderful day.